Good morning, all. Again, welcome you in this Diagnostic Day-10. Today, we will discuss some very important topics which are concern for everyone, like measurement uncertainty, lot acceptance testing, risk management, and how to maintain our records of equipment. What is this IQ? What is this OQ? What is this PQ? So now we are starting with our discussion on measurement uncertainty. Measurement uncertainty means what are the factors which can affect our results? How much variation is possible in our results when we are releasing a particular test parameter? Although there are other things also, like biological variation. What is this biological variation? This is the, you can say, variation during the course of disease. Biological variation means variation during the course of disease, like some physiological changes in the body, or during growth period, there are some changes, or with aging, biological parameters show some variation. During pregnancy, there is some difference in the different parameters, menopause, or some other normal circumstances, or some cyclical variation, some daily variation, or you can say seasonal variation or monthly variation, or there is some change in the internal homeostatic mechanism of individual, which also causes some variation. Suppose somebody is dehydrated at some time, at other time somebody is overhydrated, this will also cause some variation. All these are biological variations. These also affect our results. We have to keep in mind these also, but we are not discussing this today. This is again a big topic that we will discuss at some other time. For pre and post measurement process, some pre-analytical, how we have collected sample is properly collected or not, that affect whether the patient was fasting or not, if it is required. Post measurement process, if some calculation is involved or typographic error may occur. So all these things causes variation. But here we are today concentrating more on the measurement uncertainty. In this, we have to see what exactly we are measuring. Suppose it is CKMB, whether we are measuring CKMB mass or enzyme activity. And what are the sources of measurement uncertainty? What are the variables possible? And how we can statistically estimate this variation? Because variation in our result shall be as minimal as possible to make the result as useful as possible. Then how we can apply this quantitative estimate of uncertainty, whether we are estimating this in some quantitative test or in qualitative test, where we are measuring something as an intermediate step. And where is the utility? It has utility in the clinical laboratory, where clinician has to take some decision, and as a laboratory person, we are helping our clinician to take better decision. Or it is also useful for IVD manufacturers. If they calculate how much uncertainty they are getting, so they can develop some tool to keep this variation as minimum as possible. Because this information is important. Measurement uncertainty. Because with this, a specialist in laboratory medicine can correctly perceive measurement, ki how much variation is there, and provide reliable patient care and safety. This we will discuss with some examples how this information is useful. Now see what our standard says, ISO 15189, and many of you must have attended these ISO 15189 training program, or many of you must be working in accredited laboratory. At present, we are using third edition of this ISO 15189. This concept first came into picture in the second edition of ISO 15189, and their standard said, laboratory shall calculate uncertainty where relevant and possible. But in third edition, which we are using at present, they removed this choice. They said, laboratory must calculate measurement uncertainty even when irrelevant and impractical. This clinician will decide. Now the only certainty about the measurements uncertainty is that ISO has made it a commandment. That means now it is essential. So they are saying whenever they use this word shall, it means it is must. Laboratory shall determine measurement uncertainty for each measurement procedure in the examination phase used to report measured quantity values on patient sample. Laboratory shall define the performance requirement for the measurement uncertainty of each measurement procedure and regularly review estimates of measurement uncertainty. If you are reviewing regularly, then you will come to know how much variation is there in each parameter, whether it is increasing, decreasing, or it is stationary. And they said, when you are interpreting quantity values, you have to use this measurement uncertainty. And on request, you can make this information available to laboratory users. You can provide this information to clinicians. You can have discussion, what is this concept, and you can provide this information to clinician. And how they will use this, what is the benefit of this for them, that we will discuss. And now they are saying, where examination include a measurement step, but do not report a measured quantity value, there also you calculate uncertainty, where it can affect the interpretation. What are these tests? These also will be discussed. Here I am telling you this is important, and all these things will be discussed. Now see, all of you know, one SD covers 68.3% data points, 2 SD covers 95.5% data points, 3 SD covers 99.7% data points. What is the utility of this information for us? We want to see how much variation is possible in our result when we are reporting a patient value. Now, what is the statistical tool we have with us to check the variation in our data? That is standard deviation. Standard deviation or coefficient of variation tells us about variation in our result. Now, we say 2 standard deviation is adequate coverage of any data. For biological reference interval also, we take central 95%. That means 2 standard deviation. So now we will exploit this information. Tool for variation is standard deviation, and when we use these 1, 2, or 3, these are coverage factor. 1 SD covering 68.3% data point, 2 SD covering 95.5% data point, 3 SD covering 99.7% data point. So now we are saying 95% is covered by, when 2 is covering 95.5, 95 is covered by 1.96. Therefore, in your references, in your document created by NABL 112, you must have seen they have also mentioned 1.96. This is the reason. Otherwise, it is close to 2 only. If you are multiplying, suppose your standard deviation is 2, you are saying 2 into 2, my measurement uncertainty is 4%. Or you are saying 1.96 into 2, whatever you are getting, 3.92. My measurement, it hardly makes any difference. But to be mathematically more accurate, we say 95% is covered by 1.96 standard deviation. So therefore, they have mentioned. Otherwise, it is close to 2 only. So now I will give you some example. Suppose you are reporting a neonatal bilirubin level, and the bilirubin is 22.4. Clinician want to know bilirubin, he want to decide whether this child is looking very yellow, whether exchange is required or not. And suppose the cutoff limit for the exchange is 23. Now the clinician is calling you, that neonatologist is calling you, madam or sir, you are saying it is 22.4. By any chance, can it be more than 23? Because I have to decide about exchange transfusion. If I am avoiding exchange, then suppose actual bilirubin is more than 23, it may cross blood-brain barrier, will be deposited in the basal ganglia, connectors, and ultimately severe mental retardation. Whole life of the child will be spoiled. Or if I am taking decision in favor of exchange, based on my clinical judgment, I don't have any biochemical support for this. This is a preterm neonate. If anything will happen, I don't have any supportive evidence with me. So now please help me in this situation. Now, what is the answer with you? If suppose you tell them, see, at this level of bilirubin, our control values are showing for the last 6 month data SD of 0.2. That means measurement uncertainty 0.4. Whatever we are reporting as 22.4, I can say with 95% certainty, maximum value possible is 22.8. According to me, you can wait for some time, then get this bilirubin done again, and you can take decision accordingly. Then the clinician will also understand. They have also read this statistics in their ESM Park and Park or in other references. They say, okay, suppose now after 4 hours, they are sending sample again, and the child is on phototherapy. Now the bilirubin is 22.8. They will understand, oh, child was on phototherapy and still the bilirubin has progressed to 22.8. Considering the uncertainty in the laboratory, it may be 23.2. So it is better if I go in favor of exchange transfusion. So this information is meaningful for them. Sometimes what happens, suppose we are reporting platelet count, and today in the morning, platelet count is 48,000. In the evening, it is 50,000. Clinician will say, oh, the platelet has started improving. Again, next morning, now the platelet is, suppose, 47,000. In the evening, suppose it is again 50,000. Then they will say, the laboratories are providing us erratic report. Next day, what they will do? Oh, you take 2 samples, send one, submit one sample in the hospital laboratory and submit another sample, some other laboratory. Bring both reports to me, then I will analyze in the afternoon. And this is our day-to-day problem. If you explain them the concept of measurement uncertainty, see, at this level of control, measurement uncertainty is suppose 2000 or 1500. Suppose it is 1500. Now, what is the measurement uncertainty? Multiplied by 2, 3000. Whatever you are reporting as 47,000, considering the measurement uncertainty, this may be 50,000. And whatever you are reporting as 50,000 or 49,000, that may be 46,000 or 47,000. This much variation can be attributed to uncertainty associated with that measurement. So if you explain them this concept, they will also understand. They will also understand and they will take decision accordingly. If suppose in the morning it is 49,000, in the evening it is 55,000, measurement uncertainty is 3,000. Whatever you are reporting as 49, that can be 52. Whatever you are reporting in the evening as suppose 56,000, that is 53. You can say there is some little increase in the platelet. Then you can say, but this information is useful for the laboratory to interpret results and for the clinicians also. So this information shall be provided to clinicians on request. Now see, for qualitative tests, like your HbSAg, HCV, HIV, hepatitis, different antibodies, anti-HCV antibody, this measurement is an intermediate step. But you can calculate measurement uncertainty because you are measuring some quantitative value as an intermediate step. This is useful in the interpretation. See, suppose for anti-HCV antibody, your cutoff value is 1. You are getting absorbance in your fully automated ELISA or ELISA reader, you are getting absorbance and you are comparing with the cutoff value. If it is less than cutoff value, you are saying it is negative. If it is more than cutoff value, you are saying it is positive. And suppose you are running positive control daily. 1.3, 1.28, 1.32, 1.25, 1.34, different these. And suppose your standard deviation is 0.1. What will be the measurement uncertainty? 0.2. Now you are saying, suppose in a patient result is 0.6. If you add this 0.2, it is 0.8, still less than 1. Your cutoff value, you can say it is clearly negative. But suppose it is 0.9. Then what you will report otherwise as negative, 0.9 is less than 1. If you consider measurement uncertainty, which is, we are assuming 0.2, it may be positive. Similarly, a positive result may be negative. This you have to report with caution as a indeterminate or borderline, whatever term you are using, and you have to tell your clinician, see, get this repeated after 1 week or 10 days, whatever you're deciding. Generally, this serological test gets settled by this time, either clearly negative or clearly positive. But this exercise is important. Otherwise, sometimes what happens, one laboratory reporting as negative, another laboratory reporting as positive, without considering measurement uncertainty. Clinician is fighting with both the laboratory, patient is fighting with both the laboratories, and these laboratories are fighting with their company people. To avoid all this, it is better if we use this concept of measurement uncertainty. Now we say we apply this concept of measurement uncertainty. This is in relation to qualitative tests, serological tests. This concept of measurement uncertainty we applies to our different tests, whether quantitative or qualitative, as we discussed, and there is some variation. But what are the reasons of this variation? This we have to understand. See, there is one term, repeatability. What is repeatability? If all variables are same laboratory, same instrument, calibration, same instrument, same water quality, same calibration, observer is same, all variables are same. You can say your within run situation. In your machine, in the same run, you are putting these controls at 2 positions within run. All variables are same. Now, whatever difference you are getting, that is the variation in your repeatability. Now, if suppose you are checking variation between laboratory, one test, same test in one laboratory and then another laboratory, same control sample. That is between laboratory. That is reproducibility. How close results are to each other. In between these two situations, all variables are same in first situation. In second situation, different laboratories. In between, what happens in one laboratory? Suppose we are checking on different days how much variation is there, different reagent lot, different calibrator lot, different control lot, different water quality with different variables at different time. Because situation will change over a period of time. We are running the same control. So this variation is called intermediate measurement precision. You will find this term in your ISO 15189. So this is what they try to say through that statement.
Good morning, everybody. I'll be in the next 45 minutes, I'll try to give an introduction to risk management in medical labs. As such, this qualifies for a full-fledged 2-day workshop or seminar. Nevertheless, I'll give an overview of risk management, which is very ill understood or misunderstood during our assessments. Right. So this is the objective of this talk, an overview of the definition of risk, the process mapping, the components of risk management, so to say, the risk identification, evaluation, planning and mitigation, and monitoring and review. These are the different tasks under risk management. So what is risk? Risk, we have number of ISO documents that address risk and risk management. The foremost one is the document for risk that defines risk as the effect of uncertainty on objectives. Very complex sentence, actually. That is how all the standards are written. Objective is what we set out to do. What we set out to do in the lab is to give an accurate and precise result within the within the required period of time, which can be very quick in case of some of the tests and which can take a day or two. So the objective is to give a correct and accurate result to patients. Then what is the effect of uncertainty on this? That means while setting out to do this, what are the things that can affect the activity in reaching the goal? So that is called the risk. So what are the uncertainties? Events which may or may not happen. Uncertainties caused by lack of information, then includes negative as well as positive. we'll go to the simpler version of this, right? In common terms, what is a risk? Risk is a probability or threat of deviation, loss, injury that is caused by weaknesses in the system, and that may be avoided through a preemptive mechanism. So an incident is not a risk. Incident is something that has already happened. Risk is something that is waiting to happen and which has an impact on the results. Okay, so is it something uncommon? We all do risk analysis every day. We have to reach, let us say, the office at 8 o'clock or 8:30. So we keep a wake-up alarm. Most of the people who are not confident of reaching in time. So what is it that they are addressing? They address a risk of missing the timing, missing the bus, or being impunctual, being late for a meeting or whatever. So that is a risk mitigation mechanism. I don't want to end up being late. My objective is to reach on time. So this is a vulnerability. I tend to oversleep, or I slept late yesterday. Whatever the reason, that is a risk I face, and that meeting could be very, very important. So that is the criticality of the risk. Risk is there, and how severe is the risk depending upon why I want to reach in time. I want to reach on time where I am the boss of the meeting. The risk is less probably, but if my boss is going to address the meeting for the same delay, the risk is high. The effect is high. So that is how we keep on analyzing risks in our day-to-day life. Second, of course, very commonly we do is there is a crossroad or a traffic signal. How much risk are we willing to take while crossing that, right? So we make a momentary judgment on what can be the risk if I either skip the signal or if I just quickly cross the crossroad when there is no signal, whatever way. So what is it that we assess using so many things? We look forward, we look at the sides, we look at the mirrors that we have. Nowadays, the mirrors are extremely good with all kinds of angles and then the concavity of the lenses so that our visibility or the risk detectability is very good, but still, accident happens, and that is a poor judgment of risk detectability. This is how we work during our daily day-to-day life. It's something that is part of life, but in the lab, what happens if everyone starts taking small risks? The overall risk is going to be very high because it's a system that we are talking about, right? So the risk management is actually very natural to most of us. Six questions that we always ask. One is, what is my goal, or what is my objective? What I am setting out to do at this point of time? What are the things that can affect my goals? So that is the risk identification. Maybe there are 10 traffic signals on the way. Same way, there are 10 different steps in my process. So I collect a sample somewhere, I transport it to one place, then segregate, and then aliquot, send it to different departments, then perform the test. So multiple actions are there which are not the same with every lab. So the risk identification I need to do depending upon how many actions I need to do before I finally issue the result. Then what is important in this is the severity of the effect and frequency. So having identified the risks, how severe the effect can be and how frequently that can occur. That is called the risk analysis or evaluation. And what do I do about it? Once I know the risk, that there is a risk, that is called a risk control or risk mitigation. And later on, we need to see whether the measure that we have taken, did it really work? Have I really controlled the risk? Did anything happen at all? Then review later on to see whether new risks have developed in the system. So this is a cyclical process that's expected to be done by everybody who performs testing and releases the result. So there is another document called ISO 14971 that addresses the risks in medical devices. This is exactly what I said. It is written in a more official way. Now, coming to ISO 15189-2012, which most of the diagnostic labs follow, are expected to follow, whether you want to get accredited or don't want to get accredited, one needs to follow these quality principles while running a lab. So the clause 4.14.6, which talks about risk management, this is just a sentence, but then it covers the entire lab operation. It says the lab shall evaluate the impact of work processes and failures and on examination results, and it shall modify processes to reduce or eliminate the identified risks and document the decisions and actions taken. Right here, it doesn't talk about accidents and whether you have installed a hazmat cupboard or whether you have installed an eye wash or shower. No, this is very specific to examination results, and most of the labs make a mistake here by saying that we have addressed or we are doing risk management. We have installed the shower, we have installed eye wash in every place or hand wash everywhere. So that is totally different from what exactly the standard wants. The standard wants the lab to look at process risks and not the physical risks, which have to be addressed under some other clause, under safety. So this risk management which we are talking about is not related to the physical safety or chemical safety or biosafety, for which there are different guidelines and different criteria. So please, the first thing is, do not mix up that with this risk assessment, which is a very common problem when we do assessments and we see the labs documents, and basically that is an understanding issue. Here the risk is on the work processes, what can impact the correctness of the result or the repeatability or the timeliness of results. So that is what it means. So that clarity is very important when we are addressing risk in a medical or a diagnostic laboratory. So that is this is the risk management process. The first thing is establish context. The context for us is patient reports. The correctness of the quality of and timeliness of the test reports is the context for us. There are other risk management processes where the context may be financial risk, it may be an operational risk, it could be like a safety, physical safety risk of the device risk, depending upon which organization at which point is doing this risk management process. For us, we take the context as the correctness of the and timeliness of the results to be useful for patient management. So having established the context, what are the things we need to do now? We need to identify what are the risks we have, and then we have to analyze the risks. Having identified them, we have to see what is the effect of these risks, ultimate effect of these risks, and evaluate them, because you might end up with, say, about 800, a list of 800 risks or 1000 risks, which is not uncommon, but we can't address all of them at once. So we need to evaluate them and see which takes the priority for now. So that is called the evaluation. And then treat the risks, treat them so that they either disappear or they become less, so less that it becomes acceptable, or sometimes you may not be able to do anything. You will have to accept it when it is at a low level, or you might even decide to stop that particular activity. So that is called treating the risk. What are you going to do with the risks that you have prioritized? And then having done this, the next thing is monitor and review the actions periodically, and then communicate with people who are involved in the entire work process. That is our technicians, our other non-technical staff who are involved in various stages of laboratory work, and also consult with them about their opinions and participations. This is putting the risk management in a nutshell. So how do we go about? A lot of theory is available. You go to net, you will have loads of risk management documents, but finally, what we need to do has to be understood clearly, right? So how do we go about it? I want to say, implement risk management in my laboratory. If that is that objective, what do we do? The overall goal. What is the overall goal? The overall goal is to reduce adverse consequences to an acceptable level for every activity along the testing process. Again, it has something to do with the sample handling, analysis, the process flow, safety, keep it aside under different clause. Right. So this to reduce adverse consequences on the sample and on the results and the reports. The first thing is the goal to be reached. Only when that is clear, the risks that lie along the way can be correctly identified. We must know which path we are going. If the path is not known, then the risks cannot be calculated or identified. So each lab has its own road and its own risks. They are not common. Step 1, list the tasks. So to list what are the tasks that we are doing, we need a process flow chart. That's the first requisite with all the inputs. And the second is the risk identity. Having made the process, identify the risks. Okay, so as far as the risk identification is concerned, as I said, one size does not fit all. Even within the laboratories that belong to the same group, there is a common risk assessment plan, nicely written, submitted by the corporate office, which where they say this is common to all, and that doesn't happen because each lab is different. Each lab has its own risks. So each lab has to prepare its own risk process and the risks to be identified. So the first step in risk identification is process mapping. So it's a graphical representation of all the steps, starting from the request. So having, okay, we will see that in the next slide. The next is a fishbone diagram. Having mark. The second thing is, what are the influences on each process, which can be done using what is called a fishbone diagram. Then you arrive at a table where all the factors are listed as a table. Pre-analytic, analytic, post-analytic, every step has to be clearly done. So the first step is the process mapping. Process mapping is, this is a general process mapping, but each lab will have small variations. Specimen ordering, where all it can happen, right? If you are a referral lab with international, collection of samples, then, the ordering happens at so many places. And what is important here is the correct test has to be ordered for the symptoms. So involves probably a physician interaction and then physician education, which cannot happen every time frequently, because some kind of a program or a document or a information guide should be available for specimen ordering. Starting from that, the next step is the collection. This will happen at a different place, and then the transport, processing, and then testing, result interpretation, reporting, and other post-analytic considerations, probably an LIS interface and automated release. So many post-analytical things are there, and how you release the results, what is the mode of release, paper, email, cloud, anything. So all this, the process has to be mapped. The overall, the gross process has to be mapped first for your lab. Then the next step is the fishbone diagram. For each process that you have identified, for each process that you have identified, it's better to create a fishbone diagram. So maybe for pre-analytical alone or sample collection alone, what are all the inputs a person will be involved for sample collection, then the environment in which the sample is collected, then the materials that are required, maybe the specimen tubes. If you are doing multiple collections from different nursing homes, the tubes will be different. Do they have the same effect on the result? That's a risk, right? And then the methods, how many people are involved, what is the method of transport to the lab, and what are the equipment used? Are they centrifuging and sending it, or how is the transport done? So if you take just the sample collection and reach to the lab, there are too many factors that influence. Put all these influences, this is called a fishbone diagram. Under the fishbone, under the factors, you can always add things that can lead to, that can be a variable. So that is how the fishbone becomes very big and with lot of branches. The more factors you identify, the fishbone becomes a big complex diagram. So having done that, now put it on a vertical way by listing down the steps. Like, what is the procedure? Just blood collection in chemistry, it may be just one step. For that, what are the different steps? Second, I have just left it because it's just a sample. And then what can go wrong? One of the things that can go wrong may be a hemolysis. Again, it depends on the tests. What can go wrong? Then what is the effect? A wrong value might come. What is the outcome? A wrong report. So this is a risk. So we know that this is a risk for the results, correctness of the results. So keep preparing a table, identify who is doing it and what can happen to various factors. So that becomes the risk identification table. This will be very exhaustive because each activity you will have to split. The more knowledge you have, the bigger or the more risk attitude you have, the bigger will be the table. Okay, then having made the list, now what are the risk identification techniques? How do people identify risks? One, by brainstorming. Ask the people, involve the people who are actually doing the test. A risk assessment can never be done at the high level. It has to be done with the people who are actually performing the activities, and discuss with them how they do it. As they describe the process, how they are doing it, you will know, oh, this can be a problem, that can be a problem. So that is a brainstorming that you do first. Then there are a lot of checklists. You can look at the checklists, you can look at the records where there is some ambiguity or the errors. Then if people have not understood something and made wrong entries, then that is a risk for you to address. Then systematic, there are very systematic rules, like the systematic. These are terms which we will come across. We will see FMEA, etc. has so many methods, management jargons are there, but what we need to know is a simple logic. It doesn't matter if you don't know the jargons of the management. As long as you know what you have set out to do and the logic behind it, it's good enough. A combination all is required. All this is required because even for you to develop a fishbone diagram, a brainstorming is a must. So that is the identification techniques, right? So where all do we, what are the sources for us? It may be triggered by internal audits. Look at the internal audit reports. Somewhere people might have written their concern that this is an area of concern. No non-conformity might have come. So look at that. Second is occurrence management. Incidents that have already happened will identify a risk that you have overlooked. So look at the records of the occurrence management, incident records, accident records, proficiency testing. Probably there is a trend. You might not have failed, but then over a period you are looking at a bias that is developing in the proficiency testing. So that's a risk because very quickly your essay is either going to fully fail or already you are in a very large bias. And then the quality control records, how frequently the quality control is going out. You might have got it, but then how frequently it is going out and then getting itself corrected, that's a risk. Then the revised results. The revised results, why did they happen? Why it actually came to a stage that you had to revise it? That means some risk has been overlooked there. Then customer complaints, proactive processes, that is the brainstorming and the observation of the activity, what's happening in the lab. Physically look at the processes, stand and see what could go wrong in these processes. And these are the other systematic management tools that I said, which over a period one will learn and then put them into practice. and continuous daily observation. These are the different things that's going to alert somebody about the risks that are there. Now, having identified the risks, the next step is evaluate the risk. How do we evaluate the risk? Now, we need to know so many risks have come, easily some 800,000 or even more. You can comfortably list in any laboratory when you start. So now we have to see how many you have already addressed. Some of them you might have already taken some measure. For example, quality control. Quality control, internal quality control is a risk mitigation activity. You expect that something may go wrong while doing the analysis. A person might not pipette something properly. A person might contaminate, right? If it is a bacteriology or a molecular, or the equipment, if the lamp is failing, not fully failing, or if the aspiration isn't good, if there are air bubbles. These are all the risks that happen during a test that is done even in an automated equipment. So imagine the manual things. Manual things have more risks. So these you have already addressed by running an IQC. So when you have already addressed the risk, yes, I know I have addressed it. Make a list. Initially, you write all the risks and then see how many have already been addressed by your lab. And then look at it. Are they effective? Then what remains to be addressed? And then whatever is remaining, now we need to know how severe are they and how frequently are they likely to occur, and do I have a detection mechanism at all for them? So that is called the risk evaluation. So how do we do? This is the list of identified risks. Control mechanism is already in place and you think it is effective, no action is needed. Then but there is no control mechanism, you evaluate it based upon the severity, criticality, and the detectability, and look at the risk now. If it is an acceptable risk, it's very rare, it's not severe, and the detectability is good. If it happens, I would immediately pick it up. Then you don't need to take any action, you can observe. But if it is not so, then the risk control or mitigation is required. How do we do these things objectively? So in the same risk identification table, now you have another 2 columns. Is it prevented already? Yeah, I have an SOP, I have some indicators, and it looks good. So I don't need to do anything about it. So maybe if you have identified about 1,000 risks, 500 to 600 of them you might have already taken some action. Only thing, look at it whether you are monitoring them by some indicators or some records, like incident reports. If you are already doing it and you are happy, leave them. So you will be left with, say, about 400 risks. This is just a guess. It's not that every lab should have the same number. Then look at the resources now. How do I now evaluate the identify the risks? I'll go to the next one. It may be easy. Now, what are the risk analysis methods? These are all the jargons. This is just for you to know that there are so many methods in the management. Failure mode and defects analysis is what the table I showed is of FMEA. You also have the FMECA, FRACAS, FIA. There are so many methods, but you don't need to really bother about the name. Just get into the actual process of doing it. The names are not very important. The logic is important. Here, examine every step of the process, consider every way where it can fail, and develop an alternative strategy. That is the FMEA. Now, so you have the same sample example we are taking. The sample collection is the activity, hemolysis is the failure mode, which can fail. So what can happen? Wrong result. With this we already wrote. Now I have added the severity. Okay, we will see how to assess this. Now we need to know what is the effect of this hemolysis. Is it severe? Is it going to have a severe effect on our results? Then why does hemolysis occur? Multiple reasons can be there. If you are a syringe using lab, then that will be the most important cause of hemolysis. If it's a hospital, maybe people are drawing from lines. And then if you are a referral laboratory and getting some tubes from all over the country. Each one is collecting in a different tube. What is the effect of that plastic? Is it a good quality? It's a bad quality? Whether that's causing some rupture of RBCs, some lysis, you don't know. So these are all the unvalidated tubes. So this anything, it can be many, 10, 15, we don't know. You need to write based upon your practices. What are the causes that could lead to this? And then how frequently it can occur. Depends on how many. Suppose I have 100 samples coming, 80 of them are collected in the front of my eyes using a vacutainer, but 20 I don't know, then the frequency is about 20%. Then controls. What are the controls I have? If I am already having some controls, I only give the tubes, validated tubes. So then what is the detectability? Place. Then based on that, I have a scoring. I will come to the scoring later. Now, what are the actions now you need? If these are the reasons, what actions are required, and in further, and who is responsible to do this. So this is the next chart. We will expand on the table. Then, is this identified risk important? How do we systematically do that? It cannot be a subjective decision. So there are few things. One is the probability of occurrence. How frequently can it occur? Say a hemolysis. If I am using a syringe for collection with probably a 23 needle or 24 because people complain of pain, or I have more pediatric population, so I use a thinner needle. How frequently it can happen? It can happen with every drop. The potential is high. Then what is the severity of harm? If the tests that you do, look at the test menu. What are the tests that are going to be affected by hemolysis? I'm doing electrolytes. Then, the severity of harm is very high. So look at that. And then detectability. Do I have a mechanism to detect if there is a problem? Like I'm just taking hemolysis as an example because that's easily understood and very common. So is there a mechanism to detect? How do I detect hemolysis? If I'm going to detect by, okay, I have a sample rejection policy, but then if I'm going to detect using visual, then there is the mechanism of detectability is poor. Okay, I introduce some color comparator charts. Still, it's not poor, but something intermediate because again, it's not a very quantified mechanism. Suppose I have an equipment that detects hemolysis by index, then the detectability is good. This is how you need to analyze. How use the technology available using that as a standard. Where do I stand? Where is my procedures in the lab stand with respect to this? So the occurrence, the severity, and the detectability. So the risk priority number or the risk score is a product of all the three. D multiplied by S multiplied by O. Right. So you multiply all. Now, how to estimate each of them? That's a scoring. Right. There are many documents which will give, which you can refer to. Just the two documents I have given, CLS IEP 23 and ISO 14971. You are free to choose any valid references. So the likelihood, that is the frequency. The likelihood is very frequent because if I'm using in that example which I have said, syringe collection for all the collections, so it's going to be frequent because it's waiting to happen. So once a week. You can also look at your sample rejection register, how frequently you have done this rejections based on your own policies. Then probable gets 4. Occasional is 3, remote is 2, improbable. Actually, this cannot happen, but of course, there is a theoretical possibility that you cannot exclude. So that is how you classify the likelihood of risk. Then severity of risk. The severity is negligible. Actually, there is a likelihood of hemolysis, but I'm doing tests which have no bearing. These samples are getting done only for my maybe my HIV immunochromatography, where the hemolysis is not a big risk. So no adverse effect on results is 1. Minor requiring medical intervention, in the sense, you may need to do some equipments are there which minus the index and then give you the results. So some minor, if it is serious in the sense, moderate effect depending on the extent, or if it is a critical, yes, the results are not going to be there, and catastrophic, say for example in a electrolyte, I am going to give a result with a hemolyzed sample, maybe just above the upper result. If it is very high, then I get suspicious, then the patient death is likely to happen. So that is the severity by allowing the risk to go. What is the effect on the patient? So there is a table like this. You can spot the scores. This is the likelihood and this is the consequence. So the likelihood is high, the consequence is also severe. All these are very severe, moderate, and then low. Likelihood is low, severity is also low, then they come to the grade. So when these are in this matrix, you can spot all the risks. And what about the detectability? Meaning, what exactly am I currently doing anything? So if I'm not doing anything, there is absolutely no way I am detecting it. I'm just passing everything, then the rating is high. But I have a good detection mechanism, then it gets a detectability error as 1. So this is the scale. Now we have got the scales. Now multiply them by the probability, the severity, and the likelihood, your detectability, you get a score. For example, 4, 5, T. And again, ISO 14971 or EPI, CLSI, EPI, EP23, any document you net, they can use, you can say low is less than 10, mid is 10 to 20, high is 4. So now you put the score. Say out of 400, say about 50 have the score of more than 20. That means, you know, they have to be immediately attended right now. So you prioritize and say, this, anything with the high score, I will immediately take action. Mild and low, right now, I don't have enough people or the mechanism. Once this is done, I will do it after a couple of months, or maybe I keep it for my next year. So make a table and then say what is the risk that you have identified, whether it is acceptable, unacceptable, and then prioritize them. Now, after implementing, so these are the scores now: severity, occurrence, detectability, and your risk probability number. And after the action is taken, again do a review and look at whether the same process has to be repeated and see whether it has come down. So this is just a presumption. Here it is 10, and after the action, it has come to 5. So it's okay for you. So you are happy with the risk action that you have taken. So what are the ways by which you do a risk control? One, actually, most of the time, once you identify, it is actually identifying that is difficult, because you need to have an eye, almost like a obsessive compulsive neurosis mentality. If you have, then only you will be able to identify all the risks. So what we do, we look at the regulatory requirement, accreditation requirements, guidelines from professional bodies, CDC or the ASM or the AACC, they all give their guidelines. So look at that and first use that for risk control. Then peer-reviewed publications or individualized logical plans. So these are the support available for you to control the risks. So what are the different ways by which we control? We can make policies, procedures, and guidelines. So we make a change in the process, write procedures, write guidelines for the staff to follow. Institute some alarm mechanisms where the risks are common. So by way of a physical alarm or a software alarm. Then engineering controls can be instituted. Then trainings will have to be done once the mitigation measures have been identified. Then the management where you cannot totally, you are not eliminating the risk, so some emergency management plans will be needed. So these are examples of some risk mitigation procedures. Now, how do we monitor? Now we have to, having installed the risk mitigation procedures, Now there has to be a monitoring to see whether the actions have really resulted in a reduction in the problem, reduction in the effort, in the effect. So measure the residual risk like we initially identified and evaluated the risk the same way. Look at it and see whether there is a reduction in the risk probability number. How do we do this? We establish a surveillance system, include it as a quality indicator or a special surveillance program, and ask people to actively record everything and look at the effect, whether there is a real reduction in the quality or the harm that can happen. So detect changes in the risk profile. So this is the monitoring that one needs to do. So this is actually the monitoring. This is the result of the monitoring where 10 has become 5. The result of the monitoring is it has dropped down after the action has been instituted. Right. Having done this, now periodically one has to check whether it is effective. This to be brought to the notice of the higher management that we are doing this, and also periodically look for new risks will come. There is no end to risk assessment. It doesn't stop with 1 year. So initially, how often we should do the risk assessment? People ask. Initially, you need to do every year. And again, after an incident or an accident, you have to do a focused risk assessment in that area, if it is a pre-analytical or analytical, depending upon where the incident or accident occurred. And whenever a new equipment is introduced or a new test is introduced or a new activity is introduced, or if there is a change in in the work process, like suddenly you have introduced a new department, which you never had a histopathology, it has come. You never had a molecular, it has come now. Whenever such new changes in the work processes are happening, risk assessment has to be redone so that the new introduction has not affected the existing work, nor it has its own risks. So a risk assessment has to be done in between also. Once the lab is stable and you are confident of having addressed all the risks, the frequency can be reduced to maybe once in 2 years, once in 3 years. Some of the common examples where we overlook risks is improper specimen handling, patient preparation. We always look at some other risks, somebody falling, slipping, is there a handbar? They are not risks. As I told you, physical risks do not count. New lot verification, poorly done. Still, there is not a lot of understanding. This is not a forum to get into that, but then imagine that new lot verification is one of the risk areas. Method verification is not done mostly before you do a test. That's a big risk because you don't know whether your results are as expected. Have they worked as expected? We don't know if you have not done this. Supplier evaluation, non-conformity records, most of the time they are incomplete. If the non-conformity records are not done sincerely, you are missing risks. Temperature records, where you need to write the temperature, not just put a tick. The way we record things, the way we do competence assessments. For example, how often we do a pipetting efficiency in a competency assessment. Somebody in a chemistry, maybe somebody is reconstituting the controls or calibrators. If the pipetting is not good, if you have not introduced it in competence assessment, then you are going to have the wrong results throughout. Maybe there are trends, maybe there are imprecisions, it's going to come. So competency assessment. And then when there is no real-time record, this is a very big problem, writing the record after the activity is over. Maybe at every week or just, have the form, sit one day and fill up everything. These practices are there. This is a risk because you will never know what exactly happened and the risks may not be identified. These are just a few common examples where the risks are there and they have not looked into seriously. So what are the challenges to risk? It is impossible to identify and objectify all the risks. Every lab has some small amount. As long as it is a small risk and very rarely occurring, you can be a little peaceful. New risks emerge from time to time. And many risks, new people join, new changes happen in the workflow. Everything is a risk that can have an effect on the result. And many risks which are at every point, suppose you decide they are not very serious. A few risks in the pre-analytical, you have decided low score. A few risks in the analytical, a few risks in the post, but then the cumulative effect can be very high. So that also needs to be kept in mind when you do the risk assessments. Then leadership commitment is very important. Without that, it's impossible to do a risk management. And a non-blaming culture is very important, because one must understand that risks are there everywhere. We only need some intelligence and a system to detect them and be careful before it becomes very serious. So what are the standards or guidelines that we have? 14971, 22367, that is very specific for medical laboratories, and it will be useful for all of us. Then these are other documents which are worth looking at and reading if we have access to. But otherwise, if we follow the steps that I have enlisted, by and large, most of us would be in a position to manage the risks well. So
once again, good afternoon. So now we will shift our attention to lot acceptance testing. When you receive a reagent, you check many things. Whether if it is required, cold chain is maintained or not, or this reagent is not leaking from any side, it has not crossed the expiry date, and whatever size you have ordered for, it is the same size, same company. You're checking so many things at the time of receiving reagent. Then you're storing reagent under required conditions. But what is important? Before using that reagent for patient sample, you check whether this particular lot of reagent is of appropriate quality or not. Because still you don't know what is the quality of reagent inside. We will discuss this, but we will discuss certain other important things also related to our understanding of ISO 15189. So first we are discussing this lot acceptance testing. So you are accepting different lots of stains which you are using in your laboratory. Maybe Leishman stain, maybe your Zaden stain, maybe different stains related to your histopathology, cytopathology, microbiology, stains related to your immunohistochemistry, a lot of stains you are receiving in your laboratory. What is important? Whether a particular lot is acceptable or not. For this, you have to use knowledge of your subject, and you have to develop your system of ensuring the quality of a particular stain. For example, suppose it is Leishman stain for perfosphere. You are keeping few unstained slides with you, fixed unstained slides with you of normal cases, certain cases of eosinophilia, certain cases of thalassemia trait, MP positive. Now, whenever you are receiving a new lot, suppose you are staining 3-4 slides, one normal, one eosinophilia, one you can say thalassemia trait or MP positive. Now look for polychromatophils in this thalassemia trait slide. Whether you are able to see eosinophil granules properly or not, whether you are able to see neutrophil granules properly or not, you are able to see platelets, their RBC color is okay, whatever staining time you have finalized. So when you're checking, so you are happy, okay, this Leishman stain is okay with us. You are approving that stain. This is your lot acceptance testing. We use different terms for this: lot acceptance testing, lot validation, lot verification, kit validation, kit verification. Whatever term you are using, that is your decision. But standardly using the term lot acceptance testing, and to ensure this particular lot is acceptable to you. And remember one thing: if you are receiving one time 4 kits of the same lot, in one shipment, then you have to carry out lot acceptance testing only once. If you are receiving in the same shipment 2 kits of one lot, 2 kits of another lot, then you have to carry out lot acceptance testing for both the lots. If for the same lot you are receiving 2 kits in one shipment, 2 kits in other shipment, then again, whenever you are receiving a new lot, you have to carry out the lot acceptance testing. So you document this and keep these slides also in a box in your record. That is evidence you have actually performed that activity. Now, for quantitative tests, like your hematological parameters, CBC parameters, or biochemistry test, hormones, what is required? You are running controls otherwise, and you are checking whether these are within 2 standard deviation or not, from +2 to -2. For this new reagent kit also, you follow the same principle, because whenever there is change in the reagent, patient sample shall not show significant variation, and control is also like a sample only. So you can use the same principle. Yes, it is not showing significant variation. And if you want to, just to be more confident about your lot acceptance testing, you can perform the same activity with one patient sample also. This is for your quantitative test. For this, what is required? Laboratory shall have documented procedures, how they will carry out lot acceptance testing. Then, lot acceptance criteria. What is your criteria? How you are accepting? So you are saying within +-2 standard deviation. For stains, these granules shall be clearly visible. For AFB, in borderline cases, it should show positivity like that. Then evidence of this acceptance testing. If you are getting some instrument printout in quantitative tests, keep in record that instrument printout. Then some authorized person has to approve that. The procedure for lot acceptance testing, lot acceptance criteria, evidence of actual performance of this activity, and then approval by some authorized person. Whosoever is authorized signatory for that period, that person is authorized to sign that. This is how you carry out lot acceptance testing for your quantitative test. For your qualitative test, like anti-HCV antibody, HBS antigen, HIV, where you are releasing result in positive and negative. Keep some positive samples with you. Keep some negative samples with you already tested. Whenever you are starting a new lot, a new shipment, test with positive sample and also test with negative sample. If positive is coming positive and negative is coming negative, that means that particular lot is providing you appropriate result. That is okay with you. See, one person asking, when should CV percent be used? When should SD be used for lot acceptance testing? See, SD and CV you are calculating only in quantitative tests. In other tests, it is not possible. So here you are plotting Levy and Jennings chart with the help of your mean and SD. So you are using only SD for this lot acceptance testing, not CV percent. If positive is coming positive and negative is coming negative, so that lot is okay with you. So that way we have discussed these states, these qualitative test, and other consumables. See, what I always feel, what I always convey, keep your understanding, keep your implementation as simple as possible. Because all these things need to be performed by people working in your laboratory, technical staff working in your laboratory. The more you will complicate it, the more it will be difficult to follow. And this need to be followed in each and every laboratory, not only in some tertiary care hospital or very big laboratory. It is required in each and every laboratory, whether somebody is working at some remote area, in a district hospital or primary health center. This need to be implementation everywhere. So we have to understand we are keeping this as simple as possible without compromising on the quality. Other consumables, what are these other consumables? Like your syringe, if it is 5 ml syringe, how you are accepting? It is measuring 5 ml only. In one tube, take 5 ml with some other already accepted syringe, transfer that volume in the tube. In other tube, transfer with the new pipette which you want to approve. See volume is same or not. Then whether you are able to generate vacuum in that syringe or not. Culture bottles, take some swab from the culture bottle and see the culture report. It is not growing any organism, so it is okay. So like that, you have to develop mechanism to approve lots of different consumables. Dr. Vijay, I just said you are using LJ chart. Then how you are getting this 10% for lot acceptance testing, for quantitative test? Because we are using LJ chart. That way you are defining acceptance testing for other consumables. Now we have to maintain records of different equipments. What is required? Whenever you're deciding about equipment, what are your desirable characteristics? What all you're expecting in that equipment? This you should know. You have to keep all these things in your record. Suppose you are saying we need an equipment of 100 tests per hour. In this, precision for hemoglobin shall not be more than 2%. Linearity for hemoglobin shall be up to 25. There shall not be any carryover. What are these? These are your desire with that equipment. What all company people they are providing you? Those are performance specification. They are saying we have one equipment of 75 tests per hour, another equipment of 150 tests per hour. In this, you will get, say, precision of 1.5% for hemoglobin, linearity up to 22, and there will not be any carryover. So this is what they are providing you. On that basis, you are deciding, and then you are saying, okay, demonstrate these in our laboratory. So whatever they are getting, or whatever you can say you are getting, in your laboratory on that machine is called performance characteristics. What is more important for you? These performance characteristics. And these shall resemble to performance specifications as closely as possible. Now, your intention is, if suppose you are buying a hematology analyzer, same principles are true for your biochemistry, for your hormones, and other analyzers also. If you are buying a new equipment and one machine you already have with you, you would like to get results on both machines which are as close as possible. It is not like that on one machine it is 12.6, another machine is 10.2. This is not acceptable. So now you are saying how we will check whether results on both machines are comparable or not. And previous machine we are using since long and we are happy with that. For that, what you can do this regression analysis. Results on old machine on x-axis, result on new machine on y-axis. Hemoglobin on old machine is 5, it should be close to 5 on new machine. Results on old machine 10, on new machine also it should be close to 10 only. Then you will get a line at 45 degrees. This is an ideal situation. But we expect so many things in our life. We are not getting all those things. But if the line which we are getting is almost overlapping this line, it is okay with us. Results are showing very good correlation. But if results are consistently higher than the expected throughout the range, this is called systematic error, and the difference is constant, so systematic constant error. If this difference is increasing with increasing concentration, this is called, and we are finding this difference throughout the range, systematic proportional error. If we are finding some above, some below, or in some position, these are called random errors. And if we put this data, there is a calculator in WestGuard website. If we submit this data to that calculator in the WestGuard website, we get a R value, that is correlation coefficient. It should be as close to 1 as possible. If it is more than 0.9, this is good correlation, and more than 0.95 means excellent correlation. It should be as close to 1 as possible. So these also you need to calculate, and this you have to include in your IQ, OQ, and PQ, which we will discuss. Validation and verification. Generally, people find a lot of difficulty in this understanding. What is the difference between validation and verification? Validation is, you can say, some sort of claim. If you go by the definition of ISO 1519, which is given in definition number 3.26 and 3.27, those are very complicated and looking more or less similar to each other. What is validation? In this, you can say some sort of claim. Key company people, they are coming and telling you our equipment has this much throughput, this is the linearity, and this is the minimum value which machine is able to quantify. All these are their claims. These are performance specifications. These are their claims. And when you're testing that machine in your laboratory, whatever you are getting, what you are doing, you are confirming their claim. They are saying linearity for TLC is up to 1 lakh. Is it really so? What you are doing, you are not claiming anything. You are just confirming their claim. So that is verification. You have to remember two things. Same person cannot do validation, verification, both. Either you are doing validation or you are doing verification. Sometimes we say validation is at the level of manufacturer and verification is at the level of user. Because they are claiming something and we are confirming their claim. So this we have to understand. And I can explain you with a very simple story, which generally I tell during my training program on ISO 15189. Story related to Shabri and Ramchandraji. If you want, I can tell that story again, or some of you who have not attended my program. So if you want, so please write in the chat box, then I will explain the same concept with that story. Otherwise, I will proceed to calibration. Okay. See. Yes, Arun Kumar, please unmute yourself. Okay. See, all of you know the story of Shabri and Ramchandraji. Shabri was devotee of Lord Ramchandraji. When he was traveling, he was moving around in the forest. Lord Ramchandraji, Shabri offered particular fruit bear to Ramchandraji. But before offering that fruit to Ramchandraji, she tasted that fruit. What was the purpose of tasting? Purpose was, this is not poisonous, this is not tasteless. She wanted to be very sure, whatever I am offering to my God, that is really good for eating. When she offered after tasting, you can say a undocumented claim was associated. Whatever I am offering you, this is really good for eating. Lakshmanji was sitting next to Lord Ramchandra. If he would have thought, I am his real brother, she is outside party, it is my duty to check this whether this is really good for eating or not. Had this food been tasted by him, what he would have done, he would have confirmed the claim of Shabri. She is saying this fruit is good for eating. I have also checked. This is really good for eating. So you can say some sort of claim at the level of Shabri and some sort of confirmation of claim by Lakshmanji had this food been tasted by him. But remember one thing, he didn't taste that fruit in the actual story. So this you have to remember. So is it clear to all of you? Validation and verification? Please write in the chat box. Okay. See, this is concept which we generally don't read or don't pay much attention to this. You think over this, then you will get more clarity. Calibration is, you can say, method of ensuring the desired performance of equipment. Whenever you are measuring something, your measurement should be correct. Non-analytical measurements, analytical measurements. Non-analytical measurements like your speed in centrifuge, volume in your pipette, temperature in your thermometer, or you are measuring some weight. Everywhere measurement should be correct. Otherwise, these things will affect our results. What is required? For all these non-analytical measurements, your equipment shall be calibrated by a calibration lab, which is accredited for the calibration of that particular equipment. as per ISO 17025. If you want your pipette to be calibrated, select a calibration lab. See their certificate, see their copy of scope, whether in their scope, whether they have that particular equipment or not. Analytical instruments, your analyzers, where you are getting some result. Now, what is the structure of these equipments? They have light source, light is passing through a pellet solution, detected by then passing through a filter, detected by the optical system, and you're getting some absorbance. Absorbance is proportional to, degree of absorbance is proportional to concentration of analyte in the calibrator. After that, you're running controls. If control results are within acceptable limit, then you are happy. Calibration is okay, then you are running patient sample. Now, question is, what is the guarantee? The value written on the calibrator is correct. Whatever absorbance you are getting, because your all other calculations for patient, for control, based on the fact we are assuming value written on the calibrator is correct. If it is written 100 milligram per dl glucose, it is 100 only. Suppose it is 80, your all patient result will come low. Suppose it is 120, your all patient results will come high. If we ask company people, what is the guarantee? The value written on the calibrator is correct. They say, we run this calibrator as a unknown patient's unknown sample for 100 times based on higher reference material. Whatever value we are getting, then we take the mean value of this. Okay. What is the guarantee? Value written that higher reference material is correct. Similarly, for that higher reference material also, we calculate values based on further higher reference material. That way, they say we reach to national international standard. This process by which our results are traceable through calibrator to national international standard through unbroken chain of comparison is called metrological traceability. Metrology means study of measurement. So this is the concept of validation, verification, and calibration, which is important. Everybody shall have clear knowledge of these concepts. And when you are evaluating a machine, when you are buying a machine, what is required? First of all, ask company people to come and approve your space, whether this space is adequate or not. There is no excess dust, lighting is okay, this temperature, etc. All these things are well maintained. Now, how much training is required, whether this operation manual has clarity or not. You're also checking linearity of various parameters, whatever specifications they are telling you, what is the precision, how much variation is there. You can say within run, between run, carry over. A low value sample is not affected by previously run high value sample. When you are participating in quality control scheme, external quality control, what is the performance of that equipment? Analytical sensitivity. Analytical sensitivity means what is the minimum difference a machine is able to appreciate. Previously, we were using this term for lower limit of quantification also. In this hematology analyzer, we are able to estimate 4 as the lowest value of hemoglobin, or 3. But nowadays, we call that as lower limit of quantification. Analytical sensitivity means, suppose we have 3 hematology analyzers. One analyzer, 13.0, 14.0, 15.0, measuring hemoglobin like this. Second analyzer, 13.1, 13.2, 13.3. Third analyzer 13.01, 13.02, 13.03. This in first analyzer 1, second analyzer 0.1, third analyzer 0.01. Minimum difference which a machine is able to appreciate is called analytical sensitivity. Specificity means it is measuring that and light only, nothing else. You must have seen for many three-part differentials, they measure on the basis of size, and nucleated RBCs are counted as lymphocytes. So that analyzer is not specific for total leukocyte count. We have to correct. So that is specificity, analytical time, how much time it will take to complete one cycle. If suppose it is taking 2 minutes, that doesn't mean in 60 minutes you will be able to test 30 samples, or in 2 hours you will be able to test 60 samples. In between, machine may need some rest. Machine may need some washing cycle. So how much samples you are able to process in your working hours, maybe 4 hours or 3 hours, that you have to see. Cost per test, not only reagent cost, also cost of the calibrator, cost of the control. A small cost will go to small cost of the total cost of the equipment will also go in this. And you have to include all these things, cost of CMC. Then you are calculating cost per test. Staff acceptability. Your staff is able to accept all these things. They are able to gain all that knowledge. Now, when you're maintaining instrument, what is required? What all manufacturers are recommending? What is the daily maintenance required? Weekly maintenance, monthly maintenance, preventive maintenance by manufacturer. For this, you take official annual maintenance contract to comprehensive maintenance contract, whatever you are taking. All these things need to be maintained. With this basic concept, whatever we are doing on our machine, we will see what all records need to be maintained. And one thing is clear, whatever standard has mentioned in 5.3.1.7, all those shall be there in your equipment file, and you can maintain like this: IQ, OQ, and PQ. Installation qualification, operational qualification, and performance qualification. See, before installation, as we discussed, site assessment by the company people. Then you're ordering for the machine, your purchase order. When you're receiving machine, your invoice, whatever extra spare parts they have provided to you, list of those parts, operation manual is there or not, and how to use that equipment, develop procedure for your staff in simple language, and also develop SOP for various tests which you will be performing on that machine as per your clause 5.5.3. Then training package, which company people has provided. Keep all these things with you. Now company people will come. They will open machine in front of you. Visual inspection of the machine. Okay, this is new machine, not a refurbished or old machine, and not damaged from any side. Okay with me. Then how they're assembling various parts of that. You have already checked site preparation. Company people have approved environmental conditions required. Because sometimes what happens, suppose you are buying a biochemistry equipment and company people say you will get machine in 1 month or 1.5 months. In the meantime, you install one, what is that called, a deionized water plant. So that is the requirement, and how waste will be handled. Make provision of that also. Also check power. It is of appropriate voltage. There is no earthing problem. You have adequate number of sockets. It is not like that someone is fixing naked wire with the help of matchstick or adjusting multiple adapters, multiple plugs in one socket with the help of adapter. And online UPS is there if it is required of appropriate power. Generator backup is there. Then they are conducting training for your people, and after training, ask them to get post-training evaluation also, because that is important, whether people have understood the components of the training or not. Name and contact detail of support service. What do you mean by support service? Name. Till now, you were dealing with the marketing people. Now, name and contact detail of service engineer. Name and contact detail of vendor who will provide you spare parts, who will provide you reagents. Name and contact detail of product specialists. Company, they have product specialists who are comfortable with the software. They tell you information like in your HPLC for hemoglobinopathy, what is the interpretation of a particular type of graph, or what is the meaning of different type of flags in your hematology analyzer, or in flow cytometry, they are product specialists, like that. This is your installation qualification. But your machine is still not ready for the unknown sample to be tested. Get your machine calibrated. With the help of calibrator. And this calibrator shall have metrological traceability, as we discussed. You shall have calibration schedule. Maintenance of the machine, as we discussed. Daily maintenance, weekly maintenance, monthly maintenance, once in 3-4 months, company people, they are coming. And in verification, you are documenting this linearity, regression analysis, precision, carryover on your machine, as we discussed. After calibration, you are running controls, and control results are within acceptable limit. You are checking with already tested samples. If the results are comparable, you are saying, I have completed my operational qualification. Now your machine is ready for unknown sample to be tested. Now machine is in regular use. You are participating in IQC and AQAS. For this, you shall have documented procedure. This is the requirement of your clause 5.6 of ISO 15189. Also, how you will evaluate the result, and whenever there is any outlier, take appropriate action and document all these things. You are carrying out maintenance. This is the requirement of your clause 5.3.1.5. Preventive maintenance and maintenance in case of some defect, that is repair. And who are the key operators? This is the requirement of your clause 5.3.1.3. Who are the key operators for a particular period? That information also shall be available. This is your performance qualification. Maintain your records in this way: pre-installation, installation qualification, operation qualification, performance qualification. And remember one thing, whatever they have mentioned in 5.3.1.7, you are not missing any part of that. See, what is our intention ultimately? Whether this is the understanding of measurement uncertainty, or risk management, or this lot acceptance testing, or this IQ, OQ, PQ, we want to make our results error-free. Our aim is, with a little extra care in our laboratory, we can save one more life. This is our intention. Now, you are attending from different part of the country, you can say different part of the globe. In Delhi, for last 3-4 days, few days, we have started getting large number of cases of COVID. We will request all of you to stay at home whenever you're not at your working place. Maintain all those guidelines, social distancing. We are regularly conducting this diagnostic day, pathology update, microbiology update, different sessions. Stay safe, stay connected to keep your body and soul together. Thank you very much.